Jessica, for the kind comments. Thank you even more to you and Furman for your leadership here. This is the best meeting I go to every year. It's an incredible collection of people who just lean in with heart and come up with ideas, and it's highly generative. Many, many things have devolved from meetings like this in the past, and I know it will again. So ABIM Foundation is doing an enormous service, I think, and it's a privilege to be here with you all. I want to make one kind of unusual shout out also to the trainees who are in the room. Lucy and Lash and Landon and others I may be neglecting. It is not easy for a trainee to get away to come to a meeting like this. You really have stepped up to participate in the profession you're joining. And I want to just acknowledge that and thank you for your presence here. So I'm supposed to make some summary comments and then be joined by a panel of people who will reflect even better on what's gone on. I will open with a few of my own reflections and then introduce the panelists and then pepper them with questions. There was one point during the program when I guess in the breakout or can't remember, plenary or breakout, when I was invited to reflect with all of you on where my own images of professionalism come from. The answer is complicated. Obviously, I have a long life of experiences, but two incidents occurred to me, one of which I've spoken about before. I don't think at the forum, but maybe I have. One which I don't think you've heard before. So item one is my first day in medical school that I was allowed to speak to a patient. We had tutors at that time, and a tutor was assigned to me for the year to kind of guide me through the year. The person assigned to me was a man named Ed Frank. He was a vascular surgeon, and I must tell you, one of the kindest, most decent, wisest, generous people I've ever met. Every time I hear caricatures of surgeons, I actually bristle a little bit because this man taught me how to be a doctor as much as anyone ever did. Dr. Frank collected me on my first day to see a patient. At Harvard Medical School, they had something called the Red Book, which isn't Mao Zedong, it's a different Red Book. It's the book about how to conduct an interview, an examination, 20 pages of detail. I practically memorized that thing, and so Dr. Frank picked me up and we walked into the room of one of his patients, Mrs. Goldstein, I'll say, and Dr. Frank introduced me, and then I said, well, tell me, Mrs. Goldstein, when did your pain start? And Dr. Frank stopped me. He put his hand on my arm, and he said to me in the room with Mrs. Goldstein, no, Don, when you speak to a patient, you sit down. That's the very first instruction I remember at a clinical bedside. I've never, ever forgotten it. And then I sat down and I said, started talking. I said, Mrs. Goldstein, so when did your pain start? And Dr. Frank put his hand on my arm again, and he said, Don, let me just tell you something. Do you know that Mrs. Goldstein has a brand new granddaughter? Second lessons. That formation of attention and availability, focus, and then the wholeness of realizing as a human being here, that's the most important thing about her right now, despite the fact she's going to have her gallbladder out. It was interactions that shaped me. Remarkably, never really explicit. No one ever began a sentence with, this is how to be a professional. But that kind of guidance shaped me. And it's still, whenever we're talking about healthcare policy or financialization or corporatization, when you talk to a patient, you sit down and you realize that this one may have a new granddaughter. Second event happened more recently, which is kind of the countercurrent, the opposite, which I'll tell you, I've mentioned in a couple of talks in the past couple of months, but it's fresh because it's about my very best friend, the person I grew up with as a child, and we never lost contact. And in January of this year, we spent a couple of days together and had a great time. And then in February, he called me because he was not feeling well. And after a while, with help, we got him into an emergency department in New York. And lo and behold, he had highly metastatic pancreatic cancer. He was riddled with it. And he only survived a week longer, or 4 weeks longer. But when he went in for his biopsy, when he got out of the biopsy, he called me, and I said, "How'd it go, Richard?" And he said, "Well, it wasn't too painful. It was okay." He said, "But I really am perplexed. When I asked them being the system, when I would get the results of this biopsy, which of course was crucial for him, it was going to determine so much about his future. I asked them when it would be ready, and they said, in 5 business days." My friend was a writer and very tuned into words. He said, "That doesn't sound like the right language for where I am." And I said, "No, it's absolutely wrong. 5 business days. How do we end up being in a system in which the lesson is when you talk to a patient, you sit down. Do you know she has a grandchild?" To a system which uses that kind of language to tell a person dire, dire news, but only after 5 business days. That doesn't sound professional to me, but I think we've navigated into that space. So I wanted to share that with you, and that's my personal reflections on recently on professionalism. Now, the first story with Dr. Frank has the property that I could implement it myself for the rest of my life. I could always sit down when I'm seeing a patient. I can always ask first about something that really matters to the person. The second story I can't change. There's nothing I can do as a friend, but even as a physician, as a caring professional in that system that would guarantee that answer, 5 business days, was never, ever spoken again to a patient in that hospital. I am completely helpless. What's changed is scale. In my individual encounter with a patient in a hospital room or in an office, I can sit down. But the scale of the problem of changing that answer from 5 business days to a compassionate, aware answer is not something within my control. And yet it deeply, deeply affects me as a professional. And it's, after all, a reflection of my professionalism to the extent I'm related to the institution at which I'm sitting. This scale, this idea of scale, this aggregation of effort has been a theme through these 2 days. How can we exercise agency? That's a word that's come on over and over again. When things aren't right, when no matter the subtleties of professionalism arise, when it's just not right, how can we gain traction? Jessica Berwick, in her opening remarks yesterday, talked about professionalism as a balancing force and used the term, the same that Tim did in the paper, of organizational professionalism, a term that's now arriving, I believe. I first heard it from Tom Naska at ACGME. But it's not just a term, it's a question, which is, do the lessons of Dr. Frank to me about what comes first, sit down, do those lessons apply to the board of trustees of the hospital, to the finance department, to the whole structure, that organization which houses that answer 5 business days, or not? And if so, how do we make it so? What could we do in leadership or change that would allow that answer, 5 business days, never to be given again? We can debate about whether it's a job or a calling, and I think that's a useful conversation. I certainly was strongly educated by Lisa's amazing comments yesterday, but in the way, I don't think it's necessarily the right framing for my challenge here, because it's not a win-lose. It's not like I'm worse off as a doctor, an employee, in an environment in which people sit down to talk to patients. Nor am I better off when the answer is 5 business days. It has nothing to do with my own well-being as a person who wants to help healing occur. I don't give anything up by doing the right thing. In fact, I give up quite a bit by not being able to do the right thing. And that's the trade-off that I think we need to work on. The question came up during the conversation after Lisa's remarks of, or maybe she asked it, is the calling redeemable, given that we've shifted quite a bit toward 5 business days, is the answer. And I don't know the answer, and I think hopefully my panel will help think that through. We did hear just now some ideas in which, yeah, the answer would be yes. Like if I love this thing about the AI project. The heart of that project that we heard through Fred and Jessica is, I think it's an assertion of the professional presence in the artificial intelligence world. We can leave it to the techies. We can leave it to the managers. They all have a key role. But will we step up and lead, as we never did with the electronic health record, as AI enters inevitably our world? The same came from the idea, I don't remember which team, I'm picking up the U.S. Preventive Services Task Force. Great damage has been done to this country with the shutting down of the Preventive Services Task Force. I was vice chair of that task force for 5 years. It was a privilege to be there, because that was, to me, the pinnacle of science connecting to practice in a very useful and thoughtful way. Well, it may be gone now, and we can't let it be gone. And the idea of stepping up to participating in the AI world, I would add that to the action project list. Let us not rest until there is a U.S. Preventive Services Task Force in proper custody with proper duties. As we move then from individual action, sit down, when you talk to patients, sit down, to the collective challenges of organization, that's where we arrive at this concept of moral injury, which has come up over and over and over again in this meeting. This has to do with the human limits, I can only take so much before I lose the compass, before I can't sit down or ask about the grandchild. I can only bend so much before I'll break. And we've heard in a lot of the testimony in this meeting about that forcing, that point of pressure at which we can't do it anymore. Now, again, I think we need to avoid win-lose thinking. It isn't as if I'm giving oxygen, in this world, I'm taking it away from someone else. I don't think so. For one thing, as Maureen Bisignano, my colleague, says, you can't give what you don't have. So if all you care about is patients, you better take care of yourself. That's just the way humankind works. It also has never felt win-lose to me. When I close that door with a patient, and I always notice the click of the door latch as you walk in, a privileged space is created where people will say things they never will say anywhere else, where they'll share ideas they'll never share with anyone else, where they'll, I guess from their point of view, confess things they would never confess, and you get to help them. That's a very privileged space, and it's still there. And I don't think I give up anything by entering that space. On the contrary, it's a source of enormous energy and meaning in my life. That leads us to a fourth topic. First topic is individual behavior. The second is in the organizational context. The third is pushing people to their limits. The fourth is money. Financialization, because we all want to point to financialization and corporatization as the agent of the stuff we can't seem to handle very well now. That's what I think. My own view, pushed to the wall, is money has taken over medicine. It hasn't done it in all other countries. It isn't inevitable in any country, but it's happened here, and it's beginning to look irreversible. Now, there's controversy on this. For example, Erin Fusey-Brown and Troy did not agree about this. Troy, who's one of the wisest critics we have in the country of the nature of the delivery system, doesn't really believe that competition between caring and money is inevitable. Erin has eloquently argued to some extent the opposite. I don't want to oversimplify what she says. But I think the financial stuff is bending us toward breaking. And we have not, as a community of professionals and people who help professionals, stepped up to that problem. We are not pushing back with anything like the force that's going to be needed to stop this tsunami. We're trying, the unionization movement, which I'm glad about. I think it's the right thing to do, but better read what the unions are unionizing about. Because if it's about money, then it's the same thing, just on the other side of the table. We need to unionize about what we can't afford to take away from our patients and our populations and people of disadvantage. We ought to be exercising collective voice. Unions may be a great way to do it. And as remember who said, you can't bargain collectively if you're not a collective. This is a challenge for us to pull together. But darn it, I think we should be pulling together about something other than our own well-being as a profession. We don't have to be martyrs, but we have to look around us to see where the damage is and insist that it be stopped. Stopped in our country, where we are sitting by while 17 million people are about to lose insurance, where we're sitting by while our children rank at the bottom of 18 OECD countries for longevity. Fantastic JAMA article that came out about 2 weeks ago from CHOP, I think, and UCLA on the state of health of American children. It's devastating. In any other rational place that would be an emergency, we at this meeting would have canceled this agenda and gotten together and say, we're going to stop it now. American children will be better off because of what we do by time certain. Not only do we not step up as a profession, nobody's stepping up. It's as if we just have the problem, we look at it, we read it, we turn the page and read the next problem. I think we need to stop that. And that brings us to the fifth point. First is person, second is organization, third is kind of moral compass, fourth is financialization, and the fifth is politics. It's a tough call, and I think it'd be interesting in this room if I had one of those voting machines. I think we must be political. I think when 17 million people are losing their Medicaid coverage, we have to say no really loudly. I think when children in Gaza are dying by the tens of thousands in a horrific arena of violence, we have to say no. I think when there happens to be a party or a politician who stands up in favor of stopping the U.S. Prime Minister's task force or in favor of cutting food stamps, we have to say no. And I guess that's a bridge we'll have to talk about, because there are many in the room who will say, no, Don, that's not our swim line. We can't get political. We certainly can't get partisan. I think that's a luxury we no longer can claim, but we'll talk a bit more about that. We heard, by the way, this example from Lilia about what happens when you do it right, when you get political. Look at what she did from 0 to success. And that didn't happen by claiming I'm not political. It happened by realizing politics is now health. So those are some of my takeaways. I'd like to reflect more, but it's time for you to hear from people who really have other important things to say. So first, let me level set, which is, this has been a rich couple days for me. I mean, there's more ideas floating around than I could possibly handle. But I'd like to begin by just focusing on some questions that occur to me that I'm struggling with, and ask you each to respond. And in your response to that question, feel free to say more about other things you take away here. So why don't we start with you, Suzy? We got strong advice from David Goldman at the end of the day yesterday, with echoes of the Holocaust, saying that, advising us to really think hard before we are willing to adopt a victim mentality, where we just lament what's going on and then re-lament it, if that's a word. He urged us to exercise agency even where it's hard to find it. So I'd like to begin with that. It strikes me as a really important question. What does it mean not to be helpless, not to be complicit, not to feel like the victim? What does that mean for you, given where you are in your development?
Yeah, I think that's a great question, and something that I've been thinking a lot, and I think it sort of comes back to this idea of the individual versus the system as well. And so there's the idea of really thinking about that patient in front of you in every encounter and trying to get back to that and really make sure that the patients are the focus of everything we're doing. But then also I think what I've come to appreciate too is that I think professionalism, as we've all talked about, is a lot about the values. And there are the individual values, but there are also the more collective, community-oriented values. And the two can't exist in silos. They have to both coexist. And so I think that idea that being being a physician is not just about taking care of that patient in front of you, but thinking about the larger population and how can we advocate for change. I think as trainees, oftentimes it can feel like that is a lot more challenging to do, in part because we are working very long hours, but also we're at the bottom of the totem pole. But I think, as people have pointed out too, there are trainees who have really strong voices, and they've been powering some of these union efforts. We've heard from them here too, with Landon and Lash earlier today. And there are lots of examples of how powerful the trainee voice can be. And so I think part of what's really important too is really trying to re-engage trainees, think about why is it that we all came into medicine, what are those values that are so important, and how can we work together across generations to really create this mission-motivated care that we do.
Being a trainee is hard work, though. There's a lot of hours consumed in just the transformation into a physician. Do you ever feel this is asking too much of you? I want you to learn, if not the Krebs cycle, something, and also get involved in the new legislation to extend Medicaid coverage. I mean, how do you think of balancing that?
Yeah, I think it is a really challenging balance, and something that will change person by person, and that's important to consider as well. But I do think that at the core of what we do, we're still choosing medicine because we feel the values that I think all of you felt when you chose medicine as well. And I won't speak for everyone, we all have different values, but I wanted to go into medicine because I felt like I wanted to help patients, be involved in that community, and that was really what centered me. And I find day to day too, the things that bring me the most joy when I'm in the hospital are those patient encounters where I feel like I've made a tremendous impact. And I think that's true of a lot of people. And it's really hard when you feel like the systems are working against you to prevent you from providing that care for patients. And so sometimes it brings a lot of meaning to get involved in those sorts of movements too, but I think we need more avenues for involvement as much as we can. And it can't just be that trainees have to do extra work to do this, but also how can we get that mentorship and guidance to be the advocates that we need to be, and to try to create that change even when we are at the trainee level.
You're putting some of that burden on the faculty and teachers. Desiree, good to see you.
Good to see you too.
So comment, if you will, on this choice between the victim mode or not.
Well, I think I would start off by saying that I think life is hard. And I think it's so easy to default to victim. And it's oftentimes necessary for us to know how to reframe. And so for me, in the patient advocacy or advocacy world, research advocacy that I do, I am often thinking about how can I look at this situation that is not right, but do I have a role, do I have an opportunity here? And oftentimes when we see or experience people doing things that we believe aren't right, we could be frustrated. We could use a lot of adjectives that may not be suitable for this environment here. But you know, what the most important thing is to say, do I have an opportunity to teach someone, to educate someone, to help them understand, or perhaps not even understand, accept that there is a difference? Because oftentimes we feel everyone should see everything the way we do. And everyone should do the things that we do, but that's just not the reality. And so I think that, you know, it is so important to not feel as if you're a victim and that you're powerless, but to look within and to determine what tools you may have, what access you may have, and how you can utilize that in order to bring about some change that is necessary. Because oftentimes we all have something that we can do that is going to make the difference. But when you're beat down at times, I think that could also make you think that you can't, but we all have. And I think yesterday in one of my remarks, I spoke about resilience. And I think that, if we think about all of us at some point have experienced adversity, we didn't even know what we could do, but that adversity then caused us to go within, to then be able to do things in a different way, see it in a different way, and rise up. And that moment that you say, wow, I pulled that off, it helps to give you the boost that is necessary for you to think more clearly about how you can be a part of the change that you need.
If it's not too personal, let me ask, is there a moment you can remember in your own life or your own recent experiences where you felt in that pushed down victim place and then something happened and said, wait a minute, I'm going to go at this?
I have lots of those moments. We don't have that much time, right? But anywho, I would share a recent experience. I had an eye surgery, which under all accounts went well. However, I had complications thereafter. And although I think that my ophthalmologist who performed the procedure is skilled, did a great job, I trust her, I believe her, she was open to say, I don't know why this keeps happening to you. And so I need you to see a specialist. And where we've moved into medicine is that the majority of times that you go to a doctor in a hospital now, you don't get to choose your doctor. It's whoever is part of the team, which is something that I don't really like, but that's not the conversation for today. So I went to see a specialist, and she was of no help. She actually said to me that the reason why I was having the issue was because of my pigmentation. And she told me there was science behind it. And because I've done research advocacy, I couldn't quite grapple that. And I said, well, if this is an issue, there's usually a root. And I would think that you'd want to know the root. And she said, well, in a few months, if this doesn't clear up, you come back, and in a few months we'll evaluate. And I had a lot of thoughts, I had a lot of feelings, and that might have prevented me from being here today, so I didn't follow through on them. But, I had to take a moment and said, perhaps she is not the doctor for me. And I have the good fortune of living in New York City, so I'm not in an area where we lack doctors, so I'm thankful for that. And so what I did was I said, okay, thank you, and I walked out. And so I then got in contact with my ophthalmologist and said that was a bad choice. We need someone else. Either you give me someone else or I will do my own research. And so she said, no, there's someone outside the institution I think you need to go to now, given the experience you had, because that doesn't make sense to me either. And I said, well, I'm glad. I'm glad that, at least, you're an MD. And if you believe that what I thought was wrong, at least that gives me comfort, because at one point I thought I was crazy to say, why are we not trying to get answers here to address the issue that was put forth? So that's just one example, that I would share to say that I had to not feel victimized, not seen, not heard, because that was not going to help move me to where I needed to be, i.e. to see someone that actually saw me, understood, and felt that it was important to assess the issue and get to the root of it.
Maybe an interpretation of professionalism there is that the first doctor, the one who still takes care of you, had the dignity or something to say you're in charge. It's your, to defer to your hour.
Yeah, no, I appreciated her.
Jessica, can you comment a little bit on this question of victimhood versus agency and how you become not a victim?
Well, we had this conversation a little bit last night where we were talking about victimhood and the very powerful conversation that David Goldman led. And I think one of the things I was noticing is that we had that conversation on the day that we were asked to describe the problem. And I think it was a really important message because it's really easy to be the victim in this system. As a frontline clinician, it's easy to just feel like the system is crushing me. But I think it's essential that we're able to name the problems, and that not being complicit has to start with a conversation with each other like this, in which we are able to name the problems as they are without self-censorship and with honesty, and in a place where we can name that there are things driving the problems that we don't really want to acknowledge, like fear, like racism, like politics, that are preventing us from saying what we know to be true. And then only once we have named the things out loud to each other and used each other as the sort of, and the profession as a moral compass and not as a shield, are we able to actively think about, as I think many people did today, how are we going to change things? How are we going to change the course? How are we going to weave a different fabric? Also, I was totally blindsided, and I did not get any beta blockers before this, so I'm working really hard on my deep breaths.
Just keep the mic for a minute here about.
Sure, no problem.
I'll get you through this. You used the word the system, and that came up a lot, especially in the conversations about moral injury. Moral injury is sort of when the system prevents you from doing what you know to be right or what you care to do. Can you describe the system in your work? I mean, you love your work from what you tell me, and I believe you, but there are points when you are run up against the system. What is it? What is this system?
Well, there's the micro and there's the macro. I was talking to someone here, I can't remember exactly when or where, but about a policy that existed at MGH when I started there, where the cardiology service, so there's data that says if you come in with a cardiac problem and you're triaged to a cardiology service, your outcomes are better under certain specific circumstances. And when I started at MGH, one of the ways, there were like pretty strict rules about how you got onto the cardiology service, and one of the ways was to have an MGH cardiologist, which sounds problematic to me if you're talking about equity of access. It's baked in. And over the last couple of years, that has been changed. That has been modified by some of my colleagues who named the problem, saw the problem, and changed it. That's a sort of policy, but you heard stories, these amazing, powerful stories just a couple hours ago about the system. The system got in the way. The policies, it's the powers that be, and the powers that be are different in each story. And so you have to really be careful to describe the problem, describe the powers and the policies that are in the way in order to be able to then use the levers that incredible people have used to change it.
Yeah, I remember Kevin and some said Brad's comments, just saying that they said, if it's stupid, don't do it. That would be the leadership move on that, I think.
If only it was that easy. Yeah.
Okay, that's the new rule. Desirée, do you run into the system in terms of this, the injuries that you've had to avoid or suffer? What does it look like to you?
Well, I would say, one of the things I would have had a totally different response if you asked me this prior to coming to this forum. I would say that, this forum, to a certain degree, not extreme, has softened me a bit because I heard a lot over these last 2 days that I was not aware of as a patient. And although I think it's safe to say that if I experience something that requires a physician, I should be able to have expectation. However, I realize that the system, the way it is currently structured, is not always allowing physicians to really be who they were at one point. Some physicians that I know say that they push back, and although they're told to spend 5 to 10 minutes, if a patient needs 20, they're going to give it and they'll work it out. And their patients, because they have relationships with them, don't mind waiting a bit because they know that when they're in the consult room, they're going to get what they need. I'm all for that. However, listening to what has been said over the last few days, I realize that the community, patients, we don't really get to see behind the curtain. We really don't understand how the system really works. And which systems are designed which way. We come into an institution, and even as we enter the building, we may have issues, but we don't really understand why. And that could actually start the whole journey of care to be negative. And so, for me, I'm going to use or take some of the information that I've learned over the last 2 days to start sharing it with community to say, we need to really understand some of what is going on. Not that you should not have an expectation in terms of quality care, but understand that, there are other barriers that we may not be aware of that is actually shaping how things are done. Because I will say that oftentimes, which is extremely difficult, you now can't call your doctor's office. You have to call a call center. The call center, you have to wait to get to somebody. And the famous words, if this is an emergency, call 911. Well, I think most people know that if it's an emergency, they wouldn't call a call center, but they say it anyway. But once you get to someone, they're often telling you, they ask you, why are you calling? What is the need? You take the time to share that, and then they tell you that the next appointment is 4 months away, and you try to understand, how does that make sense? You just asked me, why did you ask me what was my need, if you're not now going to try to offer me some help? And then I often find myself saying, well, can I get on a wait list? And they seem to be bothered and confused as to why would I want to be on a wait list? Wait the 4 months. And sometimes your condition is going to change by then, and that's why the emergency room has become the place for a lot of people to go to try to get care, because they don't want to wait. So I would just say that, we are not aware, the community, of the various things in terms of the structure and what barriers that creates.
So if I hear you right, you're partly saying that before this meeting, for you personally, it was easier to think about the doctor or the person as not being responsive or not being, now you're feeling a little more, maybe you're both trapped on the same side of the net. And
we never talked about it, right? Because,
yeah.
Again, your doctor is not necessarily, unless you have a relationship with them, they're not going to talk about their trials and tribulations. They're just going to focus on why you're there.
It would be unprofessional.
Well, so yeah, but yeah,
Suzy,
perhaps.
What about you and this question of barriers in the system?
Yeah,
You run into them?
Absolutely. I think we see it frequently, but I think what Desiree is saying really resonates too, because I think as trainees, this is something we don't really learn about the system. And we don't learn about the system that much. And it's really easy to say the system this, the system that, but when it gets down to it, we're working in it, but do we always understand it? And I think one of the things that I've been thinking a lot about are the forces that are at play in all of this. And I have an interest in systems, and it's something I've learned about over time, but I still feel like there are lots of things day to day that I don't understand. And so if I don't understand it, then how are patients supposed to understand it?
Jessica, you're involved a lot in medical education. Do you find students and residents coming to you because they don't understand the system around them?
Yes. The system's impenetrable, and I think about, I advise a cohort of first-year students in the practice of clinical first-year course. And they routinely rave about Zuri Song's lectures in one of their courses, because I think he's one of the few moments where they feel like somebody really authentically pulls back the curtain and helps them understand what the heck is going on in the system. But I find that my biggest contribution when I rotate on the House Staff Services at MGH is it's just the system stuff. It's 90% of the patient care, it turns out, is making the system move. And if you're not taught really explicitly how to make the system move, you can know everything you know about the best, most recent GDMT for heart failure, but it doesn't make the patient get the medication they need and the procedure they need in a timely fashion.
Well, I'm getting the high sign here. And do we have time for audience questions, or a couple?
Maybe one or two.
Okay, so you have the panelists before you. Does anyone want to make a comment or a question here?
Hi, Rajiv Jain. I'm a gastroenterologist in private practice, trustee in the foundation. I want to thank the panelists, you, Don, and everybody else. I was listening to the conversations for the 2 days, made me think of another construct I heard somewhere else. When life comes in front of you, you have 3 options to choose from. You can be the victim, you can be the villain, or you can be the hero. What I've seen in this room and the panelists and the lecturers is heroes. And it's very inspiring to me, and I hope to the audience as well. And in football, hero ball works sometimes, but it doesn't work all the time. So we need the heroes to inspire us, but we need systemic change as well. So that was my reflection of the 2 days of the meeting.
And that's why, to me, it's important that ABIM Foundation is holding this meeting, because the platform that ABIM can supply to help people not become heroes, but become efficacious in all this trouble is a big platform. It's an important one. One final question over there, Helen?
Thank you so much, and thanks for that last panel. That was really powerful. Just Helen Burston, Council Medical Specialty Societies, thank you to ABIM for this meeting. I think it was a really packed couple of days. Learned a lot of good opportunities. I just want to make a comment that there are a lot of groups looking at this right now. Don and I are both involved. For example, ACGME has a new center on the future of professionalism. I hope we see this as a big tent moment. It shouldn't be done. There's just so many out there. This is an opportunity to kind of bring all the folks together to really have a constructive, shared conversation. And very much thank you, Desiree, and have patience at this table. Thanks.
Thanks. Well, please join me in thanking my panelists.